Inflammatory disorders of eyelids. Inflammations of lid margin. Blepharitis. Blepharitis is a subacute or chronic inflammation of the lid margins. It is an extremely common disease. It can be divided into the following clinical types. Types of blepharitis. Anterior blepharitis. 1. Bacterial ulcerative blepharitis. 2. Seborrhoeic or squamous blepharitis. 3. Mixed staphylococcal with seborrhoeic blepharitis. Posterior blepharitis. Mebonitis. Parasitic blepharitis.
NASH, bacterial ulcerative blepharitis. Definition, also called chronic anterior blepharitis, staphylococcal blepharitis, or ulcerative blepharitis. Chronic infection of the anterior part of lid margin. Common cause of ocular discomfort and irritation. Usually starts in childhood and may continue lifelong. Etiology, causative organisms. Mostly coagulase-positive staphylococci. Rarely, streptococci, propionibacterium, moraxella may be involved. Predisposing factors, usually none. May rarely include chronic conjunctivitis and dacryocystitis. Clinical features, symptoms, chronic irritation, itching, mild lacrimation, clinging of cilia, mild photophobia, symptoms worse in the morning, remissions and exacerbations common. Signs, yellow crusts at root of cilia gluing them together. Small ulcers which bleed easily when crusts removed, red thickened lid margins with dilated blood vessels, mild papillary conjunctivitis and conjunctival hyperemia. Secondary sequelae, lash abnormalities, matarosis, sparseness or absence of cilia, trichiasis, missed cilia, poliosis, graying of lashes, tyolosis, thickening and scarring of lid margin. Eversion of punctum leads to epiphora. Eczema of skin and ectropion, prolonged watering, recurrent styes, external hordeola. Marginal keratitis, occasionally flictinulosis, may develop. Tear film instability, dry eye may result. Secondary inflammatory and mechanical changes in conjunctiva and cornea due to intimate relationship with lid margins. Treatment, prompt treatment essential to avoid complications. 1. Lid hygiene. Essential daily, at least twice daily. Includes warm compresses for 5 to 10 minutes to soften crusts, crust removal and lid margin cleaning using cotton bud dipped in dilute baby shampoo or 3% sodium bicarbonate solution. Gentle rubbing of the eyes, fingering of lids to be avoided. 2. Antibiotic steroid ointment application, applied at lid margin, preferably at bedtime. Antibiotic eye drops 3 to 4 times daily. Antibiotics such as erythromycin or doxycycline may be used systemically. Doxycycline preferred in young adults, especially if associated with meibomian gland disease, acne rosacea, or posterior blepharitis. 3. Management of associated conditions. Recurrent styes, abscess of lash follicle, chalazion may occur. Chronic inflammation may result in papillary conjunctivitis, marginal keratitis, dry eye. Artificial tears, required for associated tear film instability and dry eye. Had seborrhoeic, squamous, blepharitis. Definition, primarily anterior blepharitis with some spillover posteriorly, common occurrence. Etiology, usually associated with seborrhea of the scalp, dandruff. Constitutional and metabolic factors may contribute. Glands of Zeiss secrete abnormal excessive neutral lipids, split by Corynebacterium acne into irritating free fatty acids. Symptoms, deposition of whitish material, soft scales at lid margin, mild discomfort, irritation, occasional watering, history of falling of eyelashes. Signs, accumulation of white dandruff-like scales on lid margin among lashes. On removal of scales, underlying surface is hyperemic and greasy, no ulcers. Lashes fall out easily, but are usually replaced quickly without distortion. Lid margin thickening and sharp posterior border rounded may lead to epiphora in long-standing cases. Mixed blepharitis. Signs of bacterial blepharitis may be superadded in mixed seborrhoeic and bacterial blepharitis. Complications, similar to bacterial blepharitis but occur with lesser frequency. Treatment. 1. General measures, improvement of health, balanced diet. 2. Associated seborrhea of the scalp should be adequately treated. 3. Local measures. Removal of scales from lid margin, lukewarm solution of 3% sodium bicarbonate or baby shampoo, frequent application of combined antibiotic and steroid eye ointment at lid margin. 4. Antibiotics, used as in bacterial blepharitis, required in mixed seborrheic and bacterial blepharitis. Posterior blepharitis, meibomitis. Meibomitis equals inflammation of meibomian glands, chronic and acute forms. 1. Chronic meibomitis, meibomian gland dysfunction, MGD, common in middle-aged persons, frequently associated with acne rosacea, seborrheic dermatitis. Cause: bacterial lipases break down meibomian lipids, chronic inflammation. Clinical features: symptoms: chronic irritation, burning, itching, grittiness, mild lacrimation. Remissions and exacerbations occur intermittently. Symptoms worse in morning. Signs: white frothy foam-like secretions seen on eyelid margins and canthi, meibomian seborrhea. Prominent opening of meibomian glands with thick secretions expressed by lid pressure, toothpaste appearance. Orifices show capping with oil globules, pouting, recession, plugging. Vertical yellowish streaks visible through conjunctiva, ducts filled with thick secretion. Hyperemia and telangiectasia of posterior lid margin around meibomian orifices. Oily and foamy tear film at lid margins or inner canthus. Secondary changes: papillary conjunctivitis and inferior corneal punctate epithelial erosions. Acute meibomitis due to staphylococcal infection. Features: painful swelling of involved gland, pressure, expression of pus bead, followed by serosanous discharge. Treatment of meibomitis: 1. Lid hygiene, at least once a day. Warm compresses, expression of secretions by repeated vertical massage, milking. 2. Topical antibiotics, antibiotic eye ointment rubbed at lid margin after massage, eye drops 3 to 4 times a day. 3. Systemic tetracyclines, doxycycline 100 milligrams twice daily for 1 week, then once daily for 6 to 12 weeks. Effective due to their anti-lipase and antibacterial action. Erythromycin, used if tetracyclines contraindicated. 4. Ocular lubricants, artificial teardrops for tear film instability and dry eye. 5. Topical steroids, used cautiously in papillary conjunctivitis. Parasitic blepharitis, lash infestation. Etiology: infestation of lashes by lice. Common in people with poor hygiene. Types of lice infestations include Phthiriasis palpebrarum, infestation by Phthirus pubis, crab louse, usually seen in adults, often acquired as sexually transmitted infection. 2. Pediculosis, infestation by Pediculus humanus corporis or Capitis body head louse. Heavily infested lice may spread to the lashes. Demodex blepharitis, caused by 2 species, Demodex follicularum, anterior blepharitis, Demodex brevis, posterior blepharitis. Clinical features: infestation of lashes causes chronic blepharitis, chronic follicular conjunctivitis. Symptoms: chronic irritation, itching, burning, mild lacrimation. Signs: lid margins red and inflamed, lice anchoring lashes by claws seen on slit lamp. Nits, eggs, opalescent pearls adherent to base of cilia, conjunctival congestion and follicles seen in long-standing cases. Treatment: 1. Mechanical removal, lice and nits removed with forceps. 2. Topical application, antibiotic ointment and yellow mercuric oxide 1 cent to lid margins and lashes. Hygiene, daily cleaning of patient, family members, clothing, bedding.